Sir is, I think, little busy, but can we have somebody who is doing the first case, sir? Just wanted
Good
to.
evening. Good evening, sir. Sorry to trouble you. Just now I set up the things. Warm welcome to all the invited faculty, Professor Rosario, Nitin, sir, and I'm sure the others are joining. Our own faculty, we have Raj Gopal, sir, Rajiv Sakai, sir, and Dr. Nishikant. We have two students kindly contributed by Dr. Sham from GMC Jammu. The other student is kindly contributed by Professor Nishikant himself from Vijaypura. So we will have the case of obstructive jaundice as the first presentation. Can I have the candidate please introduce yourself, share your PowerPoint, introduce your head of the unit, head of the department, and start your presentation. Good luck to you.
Thank you, sir. Good evening, everyone. I'm Dr. Neetu, postgraduate student in Government Medical College, Jammu. Today, I'll be presenting my case. Are you able to see my screen?
Not yet, Kana. Not yet. I think you close this window, unshare, and then start afresh.
Okay, sir.
Shut down all the unused windows. Yes. Go to the PowerPoint now.
Not showing.
No, you are come out of this. Please unshare yourself.
Okay, sir.
Your last slideshow is still on. Now you open the PowerPoint and close the PowerPoint now.
Okay, sir.
The slideshow is completed.
Okay, so I'll reshare.
Yes, now do the sharing again.
Okay, sir.
Yes, good to go. Make it full screen. Good luck to you.
Okay, sir. Thank you, sir.
Down, no? Down in the page on the right side, you find the slideshow, no? Down, down, down. Okay, there, yes, you can do that, yes. Okay.
Good luck to you.
Thank you, sir. Sir, I'm not able to see the whole screen. I need to...
What challenge do you have? Are you able to see the slides or not?
Yeah, sir. I'm able to.
Yes, please go ahead.
Yeah. Good evening, everyone. I'm Dr. Neetu Jamwal, third-year resident from Department of General Surgery from Government Medical College, Jammu. The case was moderated by Dr. Sham Kumar Gupta. Okay. So, with the history, patient named Mrs. X, she's 80 years old, a female from Riyasi, JNK. She's a Muslim by religion and a housewife by occupation. She presented to our emergency room with the chief complaints of pain right up her abdomen for 1 month and yellowish discoloration of eyes, skin, and urine for 1 month. Patient was in her usual state of health when she complained of pain in right upper abdomen for 1 month. Sudden in onset, continuous dull aching pain, mild to moderate in intensity, radiating to back, aggravated after eating food, and there was no relieving factors. Patient and her family members noticed yellowish discoloration of her eyes, skin, and urine 1 month back, which was gradual in onset, progressively increasing, and it was associated with nausea and postprandial fullness. She also complains of constipation. Frequency was once in 3 to 4 days. She will pass stools, and it was clay-colored stools. And there's a history of 2 episodes of black tarry stools, which was 1 day back. There's also a history of high-colored urine, itching all over the body, and loss of appetite with unintentional weight loss and generalized weakness. There is no history of vomiting, hematemesis, waxing and waning of jaundice, no history of any prodromal symptoms like fever, rigor, and chills, no history of any chest pain, shortness of breath, or hemoptysis, no history of any decrease in urine output and altered sensorium, and any night blindness. Past history, there's no history of jaundice in the past. She doesn't have any history of hypertension, diabetes, or any thyroid disorder, asthma, or tuberculosis, no history of any blood transfusion, no history of any chronic drug intake, and no history of any hospitalization or surgery in the past. Personal history, she takes a mixed diet, non-smoker and non-alcoholic. Her sleep is disturbed due to itching and pain in the abdomen. She has a normal bladder habits. She is married with G6, P6A1. She has 6 live children, out of which 4 sons and 2 daughters are there. All were normal vaginal delivery. Last childbirth was 42 years back, and she is menopause for 30 years. There is no history of similar disease or any other chronic disease in the family. She was taking some treatment from the quack at native place for her yellowish discoloration and pain. There is no history of any allergy to any food, fiber, or drug. So to summarize my history, 80 years old postmenopause lady presented with complaints of pain in right upper abdomen associated with progressive jaundice, itching all over the body, passage of clay-colored stools, and 2 episodes of black tarry stools, high-colored urine with loss of appetite and weight with no prodromal symptoms.
Need to go to first slide. So what is your conclusion by your history?
So there's the patient is elderly, 80 years old female. She's housewife, mostly having a sedentary lifestyle, with the complaints of pain in the right upper abdomen for the
Next slide, please.
For the pain in the right upper abdomen for the 1 month, along with the yellowish discoloration of her eyes, skin, and urine for another month, for the same month, which was noticed by her family members, especially her son. And from the history, we can I'm giving a provisional diagnosis of obstructive jaundice, most likely due to neoplastic etiology.
Why obstructive jaundice?
So because in the history, she has given a history of yellowish discoloration jaundice for 1 month, and with pale colored stools and high colored urine, itching all over the body. So so these points go towards the obstructive jaundice.
It's painless jaundice or painful jaundice?
Sorry, sir?
Painless jaundice or painful jaundice?
The painful jaundice.
Progressive.
Yes, sir, progressive.
Okay. Next slide, please.
Dr. Neetu,
Yes, sir.
can you please go to the first slide, because I want to give you one suggestion.
Sure, sir.
Yeah. You have taken, you completed these points in several sentences. Rather than making these points in multiple small sentences, you have to say like patient name Mrs. X, aged 80-year-old female, president of Riyasi, Jammu and Kashmir, religion by religion Muslim, housewife by occupation, admitted to our hospital in emergency 1 month ago on this date with following chief complaint. Then that will be more actually sound, rather than describing all these things in multiple sentences, small sentences. Second thing, can you elaborate the type of jaundice that you have described along with the 2 episodes of black terry stool? And second thing, the weight loss, unintentional weight loss, but whether this weight loss was significant or not. You have to.
Sir,
Can you please elaborate all these points?
yes, sir. Sir, she has complained of the colored stools for 1 month, and she was consulting some native quack over there for all these symptoms. But when she had 2 episodes of black tarry stools, she just came to our emergency that day. She was not admitted with us for a month. She is just admitted since 3 days now. And so black tarry stools, she complained that they are like black colored, and suddenly it was white in color. Now it is black in color. So she was worried about that. So which goes towards the Samelina. And the other point so that you're asking is
So what is the correlation between the jaundice and the black tarry stool in case of obstructive jaundice? As you mentioned, your probable diagnosis would be obstructive jaundice. So is there any correlation between the
Sir,
jaundice,
yes, sir.
deeply progressive jaundice with black tarry stool?
Sir, in cases of periampullary carcinomas, when there is a sloughing of the tumor, patient can
Very
present.
correct. So that may give rise to melena. But do you think that will be progressive jaundice or
So
some
that
other
is
word we can use instead of?
the waxing and weaning of the jaundice. But she did
So
not give.
So waxing and waning type or fluctuating level of jaundice was there in your patient, or it was severely progressively increasing jaundice?
So according to the history, she did not notice any change in her jaundice. She just noticed that it is there, but her family members said it has been increasing since a month. They did
Okay.
not see any decrease in it.
Okay. And what about the weight loss?
So her son only said that all her clothes has gone loose since 1 month. Before that, she was very healthy, and now she is very lean. They
Okay,
don't
was
have
it significant? What is significant weight loss? What should be the
the
significant?
significant weight loss is more than 10% of the weight of the person. And according to the family, it's significant because she used to be very healthy and now she's very
See,
lean.
more than 10% of the body weight, ideal body weight, in how many months, or what
In
should be the duration?
in 6 months.
Okay.
More
So
than
doctor, do you
10%.
think this is a benign disease you're dealing with or a malignant disease you're dealing with?
So as it's a short history and with a progressively increasing jaundice and described by the patient family weight loss, loss of appetite. So we are looking at probably at a malignant disease.
What are the points to support it?
She just mentioned it. Weight loss, progressive jaundice, and what else did you say?
Anorexia, loss of appetite.
Loss of appetite. Is melena in favor of a benign condition or a malignant condition?
So a malignant condition.
What is melena?
So melena is a passage of black colored stool, which is denatured RBCs in the stool.
Black color stool.
Yes.
Any other better terminology along with this?
Why is the black color due to what gives the black color?
Hemolysis of the RBC.
Huh?
So hemolysis.
No, it's a basic thing. It's not hemolysis. What component of RBCs gives it the black color? It's due to what? It's the basic why. It's due to acid hematin formation.
Yes, sir.
It's not due to breakage of RBCs or due to acid hematin on reaction with the hydrochloric acid present in the stomach.
Yes, sir.
Okay. So usually it's the history, whatever you've got. Say it's not a painless progressive jaundice. With melena, it has not. It should have gone down, but it has not. The history is not a classical of malignancy. Also, okay. And why do you think the pain is there? Can you still justify pain, but and still support neoplasia as your etiology?
Sir, in cases of carcinoma head of pancreas, there is a pain.
Okay.
In cases of the gallbladder CAs or carcinomas also, there is a pain.
No, I don't agree with that. Yes. Anything else?
Painful jaundice with fever.
Sorry, sir.
Painful jaundice with fever.
Sorry, sir, I did not get the
In
question.
which condition you will get painful jaundice with fever?
It's a painful jaundice fever.
With fever.
Cholangitis.
Huh?
Cholangitis.
Cholangitis. In CVD stones?
Yes, sir.
Hmm?
CVD stones, we will have painful. Yes, sir. We can have painful jaundice.
I'm asking, sir, painful jaundice with fever.
Yes, sir. In
In
cholangitis,
which condition you get painless intermittent jaundice?
in called leukolithiasis, CBD
Huh?
stones. Sir, in CBD stones, we can get intermittent jaundice.
Any
But in
malignancy?
CBD stone, you can't, the patient should have pain actually. Na? Painless intermittent jaundice, sir, is asking. Painless and intermittent. CBD stones jaundice that give rise to obstructive jaundice should always be painful
Yes, sir. It's painful.
with intermittency, waxing and waning type and all, fluctuating level of jaundice. What should be the cause of, reason of this painless but intermittent jaundice?
Sir,
पीजी वाली साइड है ना पीजी का सोच है सीधे तरफ है मतलब जैसे राइट साइड में वहां पे हेलो हाँ वो ना मेरी स्कूटी उधर ही खड़ी है
Yes, Dr. Yugwan, I think she was talking to somebody else.
Disturbances is there.
Yes. Kindly continue, Dr. Neetu, please. So those
Dr.
basic
Neetu?
things, Dr. Neetu, can you tell me what is Charcot's triad?
the Charcot's triad is jaundice, fever, and pain.
So it defines what? What etiology does it point to?
The gallstones.
Gallstones. And then the first thing what came out of your mouth is when the pain was told, the pain and fever was this thing, cholangitis. So what extra things does, or is there only triad in, or something extra is there in?
Pentad.
Mm-hmm. So
Or
who's named by those? Goes by the Raynaud's pentad.
Raynaud's pentad. Yes, sir.
Yes, yes. What are the extra symptoms?
So there will be altered sensorium and
Yes.
And one thing more.
One more, Neetu. Any shock?
Shock.
Septic shock.
septic shock. Yes, sir.
Dr.
Any
Neetu,
Charcot?
there are two things on this. You said Charcot's triad was pain, jaundice, and fever.
Yes, sir.
And you said
Simple.
it's due to gallstones. It's not due to gallstones.
It's due to
Where should the stones be for the patient to develop Charcot's triad?
It has to be, sir, obstructing in the CBD.
So your answer has to be specific. It is
yes.
polydocholithiasis that causes,
Yes.
and it is not a continuous.
It
It is
is a-
intermittent pain, intermittent jaundice, intermittent abdominal pain. That is the correct definition of
It is the correct definition.
Charcot's triad. It's intermittent. And it is polydocholithiasis, not cholelithiasis.
Ascending cholangitis.
Granted, sensorium hypertension related to pentad.
Well, can you move on to your clinical examination?
Neetu, general physical examination.
Sorry, sir.
General examination, show me your
Yes.
general examination.
Yes, sir.
Please go ahead with general examination. Start with the general examination.
Yes, sir. So,
You
in gen-
included general examination in history taking.
yes, sir. I'm going to start.
Actually, it is end of the history. It should be at the end of history.
So first the history and then the examination.
No, madam. After history, negative history, general examination, family history, personal history, all histories over, then you have to start the general examination.
Okay, sir.
Okay.
So,
What are the positive findings in general examination?
so there was a, should I go with the
Slides
PPT?
to share.
Okay, sure.
Your slides to share, doctor?
Sir, can you see my screen?
No, no.
No, we
No, it's
can't.
not visible.
Oh, okay. Sorry, sir. I thought I'm sharing already.
Your slides are not visible. Yes.
Yes.
Now we can
Now
see.
Okay,
We're
sir.
able to see, ma'am. Make it full screen.
Sorry. Sir. Can you see now?
Yes, yes.
Yes, we can see it.
Okay, sir. So in general examination, patient was examined after an informed consent in a well-lit room. Patient is alert, conscious, cooperative, and oriented to time, place, and person. She had an average build and well hydrated. Her height was 156 centimeters and weight was 48 kgs, which brings their BMI to 19.7. ECOG score was 1. She was afebrile to touch. Pulse rate was 62 beats per minute in the right radial artery. Regular rhythm with good volume. BP was 110 by 68 mm of mercury in right upper arm. Respiratory rate was 14 breaths per minute. Saturation of oxygen at room air was 96%. In general survey, icterus was present. Pallor was also present, examined over the nail beds. There was no cyanosis and clubbing, no generalized lymphadenopathy, no pedal edema. Neck veins were not visible, no lump palpable in the neck. Scratch marks were present over her bilateral lower limbs and back. No signs of chronic liver disease, no gait abnormality, and no obvious deformity. Coming to the abdominal examination.
Need
On
to.
Can you stop it? Then?
Yes, sir.
Yes. So why
have
did you
mentioned that-
ask? Oh, sorry. Please continue.
Sir, continue. Please continue, sir. Please.
What other thing? There's one thing you have missed. Otherwise, it's a very good description on general examination. What is the thing you've missed? See, any jaundice and there is malabsorption of what? Vitamins? Yes. Vitamin K. How will it deficiency? How will it manifest?
Settle, there might be some bruises or
Yeah, you have to see them. See for some petike or purpura
so
in
she,
the general survey. Yeah, and if you don't find them, you have to mention them. Okay. What is your idea of looking for a gait or a abnormality or a deformity
so in general survey,
pertaining to obstructive jaundice? As a postgraduate, you should be able to justify whatever you are telling. Okay. And irrelevant things should not be brought. Okay. I'll pass, yes.
Madam, can you enumerate the signs of chronic liver disease?
so there were no signs of chronic liver disease in her.
Can you enumerate any signs of chronic liver disease?
So there were no tremors. There was no petike. There was no loss of axillary hair. There was no thinning of skin.
Okay.
Difficult for me to accept that 80-year-old lady does not have loss of axillary hair.
She had.
So it is very difficult to accept that 80 years and there's no, you said no loss of axillary hair. And an 80-year-old lady? So even when the examiner asks, even when you say we're not examined it, but you should use your judgment to know what to say.
Dr. Neetu, you have also not mentioned about the performance status, which is quite significant, which should be. What is performance status?
Sir, she was ECOG 1. She was able to take care of herself, do the sedentary housework as well. She used to cook at home.
And what are the different sites where you can see for icterus? And what is the first area in the body where you find icterus?
So a sclera of eye, and we can also look in the mucous membranes. So on the skin, head and neck, on the abdomen, soles and palms,
Head and neck. What do you mean by head and neck? What are
and the face.
hmm?
I meant the skin over the face, a mucous
The
membrane.
skin is present everywhere. You cannot say that you are going to see icterus in the head and neck region. You have to specify, no?
Yes, sir. So skin, I meant.
Okay. All these things you should know. And what is the reason of the scratch mark actually present over the bilateral lower limbs and back?
So that was, she had a complaint of itching all over the body. So more she scratched on the legs at the back, she said.
Why the scratch marks are present? What is the reason of itching?
So because of the obstructive jaundice.
Because
Why?
of whatever this case is obstructive jaundice. That's why all these things are we all are sitting over here. But what is the specific reason of this itching? Why do patient itch?
So because of the bile salts, they are so irritant to the nerve endings as they deposit in the skin. There is increased histamine levels in the body. So that all it causes.
And you mentioned about the clay colored stool
Yes, sir.
and high colored urine, little bit dark brown urine.
Like, yes, sir.
So
Yellow.
what is the reason behind this? These two findings?
So there is an obstruction in the bile flow. So bile will not reach in the colon for the so the, as to be to as excreted as a stercobilinogen in the stools. That's why there's a clay colored stools. But the bile it gets spilled in the blood, which gets excreted from the kidneys as urobilinogen in the urine. So that's why there's a high colored urine.
Nitu,
No, this is not the reason. Why your conjugated bilirubin, there is no problem in the conjugation of the bilirubin. Okay.
There's
So
no-
conjugation is happening, but it's not reaching. But what is the reason? What system is actually getting hampered, actually getting involved in all these things? You have to describe exact pathophysiology of all
jaundice.
these things, because that is very important. You should know about the enterohepatic circulation,
Yes,
what is
sir.
happening, so that multiple enzymes, multiple things are
Bile.
happening.
Yes, sir. So bile is not getting excreted. Bile is not the outflow of the bile is obstructed. So because of that, bile is not entering the duodenum, and from there, the uh, um, fat is not getting dissolved. Fat soluble vitamins are not getting absorbed in the body. So enterohepatic circulation. So enterohepatic circulation is hampered.
What is this enterohepatic circulation?
The enterohepatic circulation is the bile which enters the duodenum. It reaches the it reaches the terminal ileum where it gets reabsorbed, and a part of it gets excreted into the stools and get rest in the excreted in the kidneys in the urine as urobilinogen, and almost 80% gets reabsorbed and goes back into the liver, and it gets again reabsorbed from the sinusides in the liver, and some remains in the blood, and it circulates in the body.
So what are fat soluble? What fat soluble vitamins are involved in this process?
So A, D, K, they are not getting absorbed because it gets excreted out.
Okay.
What is function of bile, Nitu?
So bile, it helps in the digestion of the fats, and it helps the
Better terminology, emulsification of the fat.
emulsification of the fat. Yes, sir.
Hmm.
And it helps by inhibiting the proliferation of the gut flora, and
One more point, Nitu. You have mentioned that icterus is present and pellar is also present.
Yes, sir.
Examine over the nail bed.
Yes, sir.
So what is jaundice basically? When we called clinically as a jaundice, yellowish discoloration of skin, nail beds, under surface of the tongue, soft palate.
Correct.
Then how it is possible to see the pellar over the nail beds? Ideally, in patient with a jaundice, don't mention about pellar.
Okay.
Hmm?
Okay, sir.
So, Dr. Neetu, which of the vital signs, among vital signs, which vital signs will be affected by obstructive jaundice?
So pulse rate will be on the lower side.
Yeah, why should that happen?
So bile has a inhibitory effect on the SA node. So because of there's a bradycardia.
Good. Yes. Probably you can continue with your local examination. Yes.
So abdominal examination. On inspection, it's normal. Abdomen is normal in shape. All quadrants are moving equally with respiration. Umbilicus. Sorry, sir.
Please continue.
Okay, sir. Umbilicus is centrally placed and inverted. Skin on skin, we can see a yellowish discoloration present. No dilated veins or scars. White striae present. No visible swelling. No visible peristalsis and pulsations. Bilateral flanks appear normal. Hernial sites are normal. Inspection of the back and spine was unremarkable. On palpation, on superficial palpation, the temperature in all the quadrants was equal and normal. There was no tenderness. On deep palpation, liver was felt enlarged, palpable 3 centimeters below the right costal margin, 16 centimeters in the liver span, in the mid clavicular line, which was elicited in the percussion as well. Inferior margin was regular and smooth surface. Gallbladder was also palpable along the inferior border of the liver, as there was a globular swelling present, which was moving with the respiration. It was felt in the upper border, was not felt. Hernial orifices are intact. No fluid thrill. There was no spinal deformity or any paraspinal tenderness present. No renal angle tenderness or fullness was there. On percussion, there was a dull note over the liver and gallbladder. Tympanic note heard all over the rest of the abdomen. No signs of free fluid in the peritoneal cavity. On auscultation, bowel sounds were present. For rectal examination, perianal skin was normal, tone was normal. There was no growth palpable. Fecal staining was present, which was clay-colored stools. There was no blood stain present. In systemic examination, rest of the systems were unremarkable. So to summarize the case, 80 years old post-menopause female lady presented with the complaints of pain in right upper abdomen associated with progressive jaundice, itching, passage of clay-colored stools, and 2 episodes of black tarry stools, high-colored urine with loss of appetite and weight loss. On examination, she is icteric with hepatomegaly and palpable gallbladder with no lymphadenopathy.
What are your points to say that this gallbladder, Dr. Neetu?
So it was a globular swelling, which was felt in the inferior border of the liver, and upper end was not. Upper end was not distinct, and it was moving
Upper
with
end.
upper border of the swelling was not palpable separately, and it was moving with the respiration.
Moving how with respiration?
So when I asked the patient to inspire and expire deeply.
How? There are 2 movements, in the abdomen. One is a craniocaudal, the other is anteroposterior. Which one are these 2 movements?
So craniocaudal.
Right. So mass situated in the right hypochondrium, globular in shape, upper border not felt, moving craniocaudally with respiration. What are the other points to say this is a gallbladder mass?
It's movable sideways as well.
Sorry?
So it was movable.
Lateral mobility. Okay. What else? What else? One more sign. Did you percuss it?
Yes, sir. There was a dull note on it.
What about the dull note? What was that dull note continuous with?
With the liver dullness.
You need to qualify these things, and you shouldn't let the examiner ask you all these things. In an examination, your flow should be continuous. Don't let the examiner to stop you on these minor things and ask you.
The suggestion, because many postgraduates are attending, so rather than committing to whether it's a liver swelling or a gallbladder swelling, you should describe the swelling and probably then commit to whether it's a liver or a gallbladder swelling. Okay,
sir.
you have to describe the swelling. Okay.
Yes, sir.
So on the basis of history and examination followed by summary, what are the, do you want to present differential diagnosis or some
Yes.
accurate diagnosis you want to mention, final diagnosis? You want to put differential diagnosis, okay.
Yes, sir. So my provisional diagnosis is obstructive jaundice due to periampullary carcinoma. And differentials can be, sir, carcinoma of gallbladder, carcinoma head of pancreas, distal cholangiocarcinoma, or it can be duodenal adenocarcinoma.
So obstructive jaundice due to, what are the points in favor of periampullary carcinoma? Just 1, 2, 3, 4, just because long list of differential diagnosis. We need to judge each and every differential diagnosis.
So for the periampullary carcinoma, so the black tarry stools goes in the favor along with the obstructive jaundice, and so age of the patient, weight loss, and loss of appetite. She had so these symptoms for a month. Maybe there is a history of longer duration, but she couldn't illustrate that because she was living alone, and her son just came a month ago and noticed all these things. So we are suspecting it might be a longer history.
But waxing and waning type of fluctuating jaundice was not there. It was progressive jaundice, you said.
She couldn't notice. So we are suspecting it might be a waxing waning as well.
It was painful jaundice. You said this was painful jaundice.
Painful jaundice brings the...
Do you think pain is suggestive of some malignancy?
Yes, sir. CA head of pancreas.
CA head of the pancreas is painful condition or painless condition? To start with.
So CA head of pancreas in later stage is a painful condition.
Why not in the initial stage?
So because when it grows, it compresses on the nerve endings, and then it...
Why the patient of the carcinoma head of the pancreas usually present in very late stage?
So
and second question, if you don't know, okay, which the prognosis of which malignancy is better relatively, periampullary carcinoma or the carcinoma head of the pancreas?
So periampullary carcinoma.
Periampullary carcinoma. Why?
It presents earlier.
Yes, very good. Okay, now tell me, differential diagnosis, what are the points in favor of the carcinoma gallbladder that can give rise to obstructive jaundice of increasing severity?
So carcinoma of gallbladder, again, sir, in favor of this, it can be painful, and as gallbladder was also palpable. So along with the rest of the points.
A soft gallbladder, does it suggest any carcinoma in the gallbladder?
So
presence of a soft larynx. And yes.
So carcinoma of gallbladder, if there is a obstruction in the neck of the gallbladder, still it will be so firm, soft to firm in consistency. If there is a cancer in the fundus.
Do you think in carcinoma of the gallbladder jaundice is a regular feature? Is
yes.
In every case of the carcinoma gallbladder, you find obstructive jaundice to the extent that eyes become sclerotic and your stool is clay colored, patient is having black tarry stool. The exact definition of this melena is black tarry stool. Not every black stool is not melena. Okay. So do you think that the carcinoma of the gallbladder give rise to such level of the degree of the jaundice that patient present?
So in the later stages, when it can infiltrate the adjacent CBD, it can give rise to
Okay.
obstructive
That's-
jaundice.
Okay.
If
So
it is-
what percentage of gallbladder will have obstructive jaundice? Say from in 100 patients, how many patients with
So a 10 to 15%.
it's lesser, it's in single digits, say 7 to 8%. Okay. So to keeping your diagnosis of CA gallbladder maybe above a head of pancreas or a cholangiocarcinoma, it should have been brought down. Okay. Okay.
Yes, sir.
Yes. Past my other colleagues.
तो उसकी बस मैंने बोला था मैंने हमारे से यहाँ पे नहीं करती है वार्ड में करा जाएगी इधर भी करा बाकी भी ड्रेस में मैं ड्रेस के नोट करते से उसको ड्रेस करके स्पेशल वर्ड टीम में
नीचे
स्पेशल वर्ड
So shall we proceed to further? Sorry, please go ahead.
Please, sir, because I am not able to hear anybody's voice actually, except you, Dr. Nitin.
Okay.
Yeah, so good evening. Can I ask few questions, Nitin?
Yes.
Yeah.
Sir.
Nothing.
Good evening, sir.
Okay, Dr. Neetu.
Yes, sir.
Yeah, just for a lot of things have been discussed now. So when you say no mass, no other mass palpable in the abdomen, what are the things which you carefully look in this patient? Yes.
So I look for any other lump in the abdomen.
No, that is the correct. But what specific? See, we are all surgeons. We have to be very clear. What is that you looked for?
So I looked for any pancreatic mass, especially in the epigastric region.
Epigastric. Pancreatic mass means like what? Head, body, tail?
So head of the pancreas.
Mhm.
Tail towards the left hypochondrium.
Left hypochondrium. For what?
Extending
Left.
towards the
No. Talk related to our patient. Our patient has got obstructive jaundice. So
Yes.
confine yourself largely to the right side. Okay, don't go to the body, tail, etc. Yes, it is possible, not that you can't get it. But in this patient, so you said no, gallbladder is palpable. So we'll hold on to that. And so I just wanted you to answer this question: is the liver palpable or not?
Yes,
First
sir.
question.
It is palpable, sir.
So you should give more details, like what? Consistency, nodularity, everything, tenderness.
So it was non-tender. It was
Yes.
the inferior border was smooth, and the
We don't
surface.
say inferior, no, just hold on. We don't say inferior border is smooth, Either it's a sharp border, surface is smooth. You have to say, surface.
Yes, sir.
Yes or no?
Yes, sir.
Why it's important?
To see any kind of so metastasis is there to give the nodularity or irregularity on the surface.
So we would like to know the consistency, the hardness or modularity or the sharp lower border, and the gallbladder will be just very close to that inferior border of the liver. One step a little behind the liver, one step little behind, as you palpate.
Yes, sir.
So that's the first thing. Why the tenderness? I asked you, tenderness of the liver or something, palpable tender liver.
It was not tender.
No, I know. So
Yes.
here, because again, obstructive jaundice patient.
Yes, sir.
So there is any cholangitis setting in, so you can get a tender liver. Okay, that is the first thing. Okay, next, what other mass? So usually in this age group patient, you don't expect any other mass in the form of whatever, say like for example, ovary, etc. Okay. So
Yes.
if there's other patients, you may have to feel some other masses like younger patients, female patient ovaries, and epigastric mass if you get set some parietic nodes in very advanced cases. Okay. Did you mention about ascites?
Yes, sir. There's no evidence of any fluid in the peritoneal cavity.
One or two other questions. What about the vaginal examination?
So, vaginal examination was normal. I did not mention it as it was not significant with our case.
Not like that. So you have to mention always,
Okay,
there
sir.
are a few things like, you might not have done in your patient, but it has to be a policy. You have to mention. Okay. Why it's important?
So there can be some pelvic pathology.
Don't say some pelvic pathology. Always talk to your patient.
So if we are
First-
suspecting a neoplastic etiology, then we have to look for all the systems.
No. What I'm trying to tell is, yes, she can have some carcinoma surgery. That's a different issue. She
Yes,
can have, in your patient, what is the relationship?
so old age with the pervaginal bleeding menopause.
No, Dr. Neetu, what sir is asking, what you are doing per vaginal examination?
Yes, sir.
For what reason? What do you want to see? Which may be related to your patients with all these findings.
Yes.
That is per rectal examination. We can check for the pouch of Douglas, any collection.
We are in a
And
so that's
similarly, what metastasis are you looking for when you do a PV?
What is the name of that particular pathology or some finding that you are looking for? What sir is asking. We are not looking for some other pathology in the ovary or somewhere. We want to establish a relationship between these findings and your patient's finding, for which
you just now said some pouch of Douglas, some shelf or something, bookshelf you have got, some bookshelf like thing. It's a shelf.
Yes,
What is that?
Bloomer shelf.
So this is how the malignant cells deposit there, So they are a little bit of indurated. That's a shelf-like projections, So that is what, see, we want you to mention all these things. So some of these are signs of inoperability. You know that, no?
Yes, sir.
So if you mention all these things, you will get, this is important. You can't miss per rectal and per vaginal and supraclavicular node, you can't miss. Maybe if you don't mention, for example, unilateral leg swelling, can these patients have some pain in the leg? When Nitin asked you about, Nagpal asked you about gait, I was about to ask, but then I was listening to you. Suppose this patient has some pain in the leg, what do you suspect? Yes.
It's a pedal edema.
You have some T for the neck and T for the leg in malignancies. What is that?
Trust.
Yes.
Question.
Yes. When you have a palpable supraclavicular node, what is it called as? Yes, correct. Troisius. And in the leg, can they have some pancreatic malignancy? More so. They can have especially from body. Okay. These are few questions which will to learn, understand the concepts. So the blood flow status will be hyper viscosity. So they can get a thrombophlebitis migraines here and there. So it's almost 30% or so it is seen. So these are a few things you should know rather than so you have to look for Sister Mary Joseph nodule, ascites, Brahmarshal deposit, supraclavicular. So that completes your diagnosis. Okay. So if you get a hard gallbladder, what you should have considered in this patient? As this has been already clarified.
Then carcinoma of gallbladder, sir, I've kept the first.
He is already told you the order in which probably you have to move the differential diagnosis a little bit up and down. So this is how you try to analyze. And does the patient have ascites?
No, sir.
So tell me which in this list you are given. Gallbladder malignancy, head, periampule, distal coil, where ascites is more common.
Yes,
by the time you get a hard gallbladder in carcinoma gallbladder, there's significant ascites already there, usually. Okay, so that's how we make it up. Yes, please take over, sir. Thank you, sir.
Yeah. Shall we move on to discussing on how about others? If we are done with the clinical
Yes, sir. Management, sir. Please.
Management, yes.
Dr.
We
Neetu,
have
how do
another
we
case.
proceed in this case?
Sir, first of all, we admitted the patient and we have started the baseline blood work in which we did her a complete blood count, her HB and platelet counts and WBC counts we checked, and then we did the liver function tests, renal function test, along with so we did ECG. Then we did the ultrasound of the abdomen for the patient.
This is
Kindly
a
tell the ultrasound.
case of obstructive jaundice, Dr. Neetu. Yeah. In hematology, what else would you like to ask?
Yes.
So bilirubin levels for
Hematology, that's biochemistry.
uh,
You said HPTC, DC, platelet count.
yes, sir.
Anything else?
So hematocrit and
No. Patient has already had melena once.
Yes.
so HP levels and
Yeah, well, I already asked for that.
Hemoglobin.
This was discussed right in the beginning. Obstructive jaundice, something is not getting absorbed.
the vitamin K deficiency and
How will you, what test will you ask for in this? Hematology.
so platelet levels.
Platelets are
Madam,
not affected by vitamin K.
which test is related with the vitamin K? And this is having very important role in the management as well.
Coaglogram.
What coagula? What is coagulogram? Ma?
So
Just give me one test.
time.
Just one test you name.
So prothrombin time.
Yes.
Yes.
All it is. Prothrombin time INR.
Yes, sir.
That's all. Okay. Next. You said biochemistry. What in biochemistry?
So we checked her liver function tests and kidney function test. In liver function, we checked the bilirubin levels, direct as total bilirubin, direct as well as the indirect bilirubin, and then hepatic enzymes, SGOT, SGPT, and along with that alkaline phosphatase. We did the
So what
Any
should be
other?
elevated?
sir,
SGOT, SGPT? Huh.
alkaline phosphatase was raised for her.
Why is alkaline phosphatase raised significantly in?
So because of the obstruction of the biliary tree,
Mhm.
so alkaline phosphatase is raised in this patient.
What's the mechanism? Why? Where it is produced, alkaline phosphatase? What cells will produce? And from where does it leak?
So
Why the level of the alkaline phosphatase increases in cases of CBD obstruction?
So it gets excreted from the CBD cells.
Which portion, which layer, which cell? It must be coming from some source, na?
Yes, sir.
So what is the source of that alkaline phosphatase? So that it increases so much in case of obstructive jaundice.
Where it is located? Epithelium of the bile canaliculi.
So
Also, it is
whenever there
present
is
in bone
obstruction, it irritates and causes release of significant amount of alkaline phosphatase from those cells because these are present in the lining of that bile canaliculi. Okay. And what about the gamma GT?
That is for the hepatocytes.
And you didn't mention about the proteins, albumin, globulin
Yes.
in your liver function test. Don't you think these are important?
Yes, sir. That's also important.
So if you are telling about the liver function test, then you need to specify starting from bilirubin, total, direct, indirect, SGPT, SGOT, alkaline phosphatase, gamma GT, serum protein, total protein, albumin, globulin, everything needs to be there. Okay, along with the coagulation profile and this thing.
Any other blood tests, doctor? Any other blood tests would you like to do?
Yes, sir. So renal function tests also.
No, that you mentioned that. Anything else more specific for your tumor? Any tumor markers?
Yes, sir. Tumor markers.
What?
CA19-9.
Right. So look, you have to, for management of the patient, is the management of the immediate management of the patient. It's investigations to confirm your diagnosis, right?
Yes,
Then
sir.
investigations to know the extent of the disease. Then investigations to know whether the patient is operable or not.
Yes, sir.
Right? That's how you go about. Okay. So for immediate management, what do you do?
We did the ultrasound of the patient.
That's fine. But otherwise, anything which you will do.
Yes, sir. I will get CT imaging done.
No, before that, you've got the patient in the OPD.
Yes, sir.
And you've sent her to the ward. You've drawn the samples. Anything else you would do? What is your what about management of an obstructive jaundice patient?
So we will start with the fluid resuscitation for her. We'll increase.
Right. So you have to give fluids. What else?
So then we gave her vitamin K as well, and
Very good.
then mannitol, as the bilirubin was.
Why mannitol? No. Why mannitol? You give mannitol to all patients with obstructive jaundice?
No, sir, not all.
Then in this patient, why will you give mannitol? Okay, no mannitol, just fluids. If you load her with fluids, what else? Vitamin K. Anything else? Hello.
Yes, sir. So
Can you hear me?
Yes. Something to replenish the liver.
Okay, look, an obstructive patient, obstructive jaundice patient, you've got fluids, you've got antibiotics, you've
Yes.
got coagulopathy, right? You've got nutrition.
Yes.
Right?
Yes, sir.
So all this has to be taken care of. Okay?
Yes, sir.
Okay. Then ultrasound. Why do you want to get an ultrasound? What are you looking for in an ultrasound?
So ultrasound will tell us the status of hepatobiliary system, and if there is any fluid present, some things can be missed.
Like if there's a tumor, lump. Where is that lump rising from?
Yes, sir.
So most important, fluids to here, but much later. First, you'll see where the lump is. What is the status of CBD, if there is stones?
Yes, sir.
Right? Lymph nodes. Okay. What else? Ultrasound. You've got the ultrasound report?
Yes, sir. I got, but it's in my phone. We just got it back today.
Just read it.
Then, okay, read it out.
It was not worked up yet, so. Say, should I read out the ultrasound report?
Yes, please.
So, in ultrasound abdomen, liver was enlarged with bilobar IHBRDs. Cystic duct is dilated with 11 mm diameter, and common hepatic duct is 11.7 mm, which is also dilated. There is a distended gallbladder, 19 into 14 centimeter well-defined solid hypoechoic lesion at pancreatic head and tail, and so no fluid, no peritoneal fluid was present.
So then how will you proceed? What will be your management next?
So we have planned for CCT abdomen for her. We want to do.
Why do you need a CCT? What are the indications for getting a CCT done?
Yes, sir. So we want to see the status of the hepatobiliary system, as the ultrasound has indicated a mass in the pancreas. And other than that, there is a dilated biliary system. So we want to do in a pancreatic protocol to see the phases, as the pancreatic protocol will show us the arterial phase, the parenchymal phase, and the portal venous phase.
In relation to the pancreatic mass, what vessels do you want to study?
So
how do you want to assess the resectability of the lesion?
So we want to see if the mass is encasing or abutting the SMV.
Yes,
So
we should talk about that when you're. Why are you going to hepatobiliary system? When you're talking about pancreatic lesion, you should be specific to pancreatic lesions.
yes, sir.
Yes. Huh.
To IVC also we'll see the relation. It's just the
Yes.
vessels will tell us if it is resectable or not.
And what else?
So the lymph nodes, if there is any
Lymph
lymph
nodes.
node
Yes.
present,
Okay.
and if there is any metastasis to the liver or
Yes.
any
Any other investigations which is upcoming and other than CT? Say if you are not able to, what other investigation which
so
is mildly invasive also? Yes.
endoscopic ultrasound.
Yes. Endoscopic ultrasound. What are the advantages of endoscopic ultrasound?
So in endoscopic ultrasound, we can it's diagnostic as well as we can in diagnosis we can get the biopsy as well.
Biopsy or cytology?
Cytology, yes, sir.
See, as a JR, you have to be very specific about the words coming out of your mouth. Okay. Yes.
sir.
Cytology, yes. And also cytology of the lymph nodes
Yes, sir.
via endoscopic ultrasound. Yes.
Sir.
Yes, pass to my colleagues, please. Any further questions for my colleagues?
Suppose your diagnosis, the first diagnosis that you have mentioned, the obstructive jaundice due to periampural carcinoma is confirmed.
Yes, sir.
So how would you proceed? You have managed patient preoperatively, you have mentioned everything, you have given nutrition, fluid, vitamin K, antibiotics, and now your patient is ready for surgery. Which surgery would you like to offer to the patient? Can you hear me, Dr. Neetu?
Yes, sir, I can hear you.
So which surgery would we offer to the patient?
So first of all, we will like to relieve the obstruction in the biliary system. We can try ARCP by putting a stent so that the biliary flow can be maintained.
That should be done in all patients?
No, sir.
Why do you want to do ERCP?
So that we can work up the patient first of all to see if it is malignant or not, and before we can
The
proceed.
diagnosis is confirmed. This is periampullary carcinoma, ERCP, whatever test you have done. Now diagnosis is confirmed. It is resectable and periampullary carcinoma with obstructive jaundice. Now you have to do surgery.
Yes, sir.
What is the name of the surgery? This is not hard question. This is very straightforward. Just single liner answer.
So we can do hepatogynostomy.
You want to do hepatogynostomy? Why do you want to do hepatogynostomy? We are thinking of some
instruction
more than this. And what is the name of the surgery for resectable carcinoma head of the pancreas?
So Whipple's procedure.
Okay. And what should be the name of this periampullary carcinoma malignancy?
Procedure. What Whipple's what? What are you resecting?
Sir is asking in Whipple procedure,
yes,
what
sir.
structure you are going to remove, and you said one hepatogynostomy. What different anastomosis you want to establish?
In that we will resect the partial head of partial pancreatectomy. We'll resect the tumor, and we can anastomose.
You leave the duodenum behind.
What do you mean by partial pancreatectomy?
So we remove that tumor And then with the main pancreatic duct, anastomos.
Do you leave the
want to
duodenum
just-
behind or not?
Sorry, sir.
Do you leave the duodenum behind? When you say partial pancreatectomy, you leave the duodenum and part of the pancreas in the C loop of the duodenum?
In partial, what do you mean by partial pancreatectomy? You will remove the head region or body region, you will leave the tail, or what you want? And another thing, will you remove the duodenum along with your pancreatic region? Yes or no? If yes, if you are going to remove the duodenum along with the pancreas, segment of the pancreas, what is the reason behind sacrificing the duodenum along with the pancreas?
So if the tumor has infiltrated the duodenum, in that case,
Tumor has not infiltrated the duodenum. Tumor is in the head of the pancreas only. Will you leave the duodenum in situ? There only?
yes, sir.
No?
Yes, sir. We will leave it.
You will leave it? What is the blood supply of the duodenum, dear? Do you have any idea of the blood supply of the duodenum and the pancreas?
Gastroduodenal artery, yes, sir. It's the same.
Can you start with the celiac axis? What are the branches of the celiac axis?
So celiac axis gives gastroduodenal. So it gives left gastric artery. It gives gastroduodenal.
No.
Common hepatic.
उससे
So the
पहले
branches of
Celiac
let's
GAT3.
gastroduodenal is not the direct branch of the celiac axis. Something else arises before. Gastroduodenal is a branch of that artery that bifurcates and gives several branches. See, the blood supply of the head of the pancreas and the duodenum, they share the common blood supply actually. No? So we are bound to remove the entire duodenum along with the pancreatic segment, the head portion. Okay. So we cannot leave. Duodenum will not duodenum will be necrosed. We cannot leave the duodenum. And what different, and suppose you don't know, this is just go and read. One thing, suppose patient is having obstructive jaundice of very high grade and ERCP is not, ERCP cannot be done, some obstruction is there. We cannot reach there. So what else you can do? And patient is non-operable. Patient is having severe jaundice, high-grade jaundice, and ERCP stenting is not possible. And patient is not surgically fit. What else we can do just to give relief to the patient? Just we want to just palliate the patient.
So we can do PTBD in that patient.
Okay. What is the full form of PTBD?
Percutaneous transhepatic biliary drainage.
Okay. Thank you.
What are indication of PTC and what are indication of PRCP?
So it for the palliative, we can do the PTBD. When we cannot negotiate by the help of the ERCP, when it is not, the scope cannot go further because of obstruction, we can choose the PTBD.
What is MRCP?
So that is imaging of the biliary tree.
What is the advantage of
Say-
ERCP over MRCP?
So MRCP shows us the anatomy of the biliary tree, which gives us a better idea which intervention to go for.
It is therapeutic also.
Yes, sir.
Therapeutic also.
ERCP is diagnostic as well as therapeutic.
Yes, sir.
MRCP is only and only diagnostic.
Yes, sir.
One last question, Dr. Neetu. Peri-ampullary carcinoma, what is the meaning of peri-ampullary carcinoma? What different malignancies you are going to include in this section?
Sir, carcinoma around the ampulla, 2 centimeters around the ampulla, those are included in periampullary carcinomas. So they are in the close proximity to the ampulla of Vater, which is distal cholangiocarcinoma. It can be duodenal carcinoma. Then head of pancreas.
Head of the pancreas cannot be the peri-ampullary carcinoma.
So when it
They
is
are two different sets. Head of the pancreas is something different. Peri-ampullary carcinoma is different. No?
around, yes, sir. Pancreatic duct also.
So
Shall
if
we
we are done with the discussion, yes, Dr. Kanak, sir, please go ahead. Dr. Nishikant, please.
Sir, shall we move on next case, sir?
Yes, that's what I was also saying.
Nitu,
Yes, sir.
you revisit this presentation. It's available in YouTube.
Yes, sir.
Assess in which area you are weak. Refer the standard books and recent advances as suggested by the faculty, and refresh your knowledge.
Sure, sir.
Good luck.
Thank you, sir.
Do you have any doubt to?
So I will first work on it more, and I will use all the suggestions I got from the esteemed faculty.
Dr. Meher, please share your PowerPoint.
Yes, sir.
Introduce yourself, your unit chief, head of department, and start your presentation. Good luck.
Good evening, sir. It's a pleasure to be here today. I'm Dr. Meher, third year general surgery PG. I am here to present the case on lateral neck swellings.
You have to share your PowerPoint.
Please share your PowerPoint.
Window.
Yes, sir.
Please do the same thing what you did for the beginning of the session.
Yes. Sir, my presentation is on lateral neck swellings under the guidance of Dr. Nishikant, sir, Professor and Unit Head of Alameen Medical College, our Head of Department, Dr. Sajid Budor, and my...
I'm sorry, Dr. You have to unshare. We are not able to see your slides. What I will request is, I will guide you. You please unshare the screen.
Unshare the screen.
You close all the windows. Just open the PowerPoint alone in your desktop.
Yes, sir.
Now go for the share screen option. What are the things you are able to see under the share screen window? You have the PowerPoint there.
Yes. Stop sharing.
Yes, make it full screen.
Yes, sir. 1 second.
Go to the slideshow.
Yes, sir. Am I audible, sir?
Good luck to you. All the best.
Yes. Thank you, sir. Is it visible, sir?
Please start.
Good evening, sir. Is it visible, sir?
Yes, you are audible and visible. Yes.
I'm going to present a case on lateral neck swelling. History of the patient is a 12-year-old female student of 5th grade belonging to lower middle class family residing in Vijaypura, Karnataka, came to the hospital on 13th May 2024 with chief complaints of swelling in the left lateral side of neck since 6 months. History of presenting illness. Patient was apparently alright 6 months back when she noticed a swelling over the left side of the neck, which was insidious in onset, progressive in nature, initially small in size of approximately 2 into 3 centimeters, progressed to the present size that is approximately 7 into 6 centimeters. It is not associated with pain and fever. This is the negative history, sir. No history of cough, evening rise of temperature, hemoptysis. No history of difficulty in swallowing, dyspnea, stridor, hoarseness of voice. No history of syncope, ear pain, deafness. No history of loss of weight, loss of appetite, bone pain, jaundice. No history of any ulcerations in the oral cavity. No history of any discharge from the swelling. No history of epistaxis. No history of restricted neck movements, neck rigidity, neck pain, and no history of regurgitation. Past history. There is no history of similar complaints in the past, no history of tuberculosis in the family, and there is no history of previous surgeries. Comorbid history, the patient is not a known case of TB or asthma. Personal history, mixed diet, adequate sleep, bowel bladder are regular, a menarche is not achieved. Treatment allergy history, not on any medications, no known drug allergy, immunized till date. Family history, no history of TB in the family or any other similar conditions in the family. To summarize, a 12-year-old female complains of neck swelling noticed 6 months back in the upper lateral left part of the neck. Initially was small in size of approximately 2 into 3 centimeters, which progressed to present size of approximately 7 into 6 centimeters, not associated with pain, fever, or any other symptom.
Dr. Meher,
Yes, sir.
can you just show me the slides 2, 3?
2, 3.
Just
Yes, sir.
that is fine. One or two quick questions. First,
Yes, sir.
pain and fever. Why did you ask that question?
Sir, pain and fever to rule out any inflammatory pathology of the swelling, sir.
Okay, patient has got, looking at her age, what is the first thing strikes to your mind?
First thing strikes to my mind is it could be a pyogenic lymphadenitis, or if it is associated with fever or pain, or it can be a TB lymphadenitis, sir.
No, go slow. 1 minute.
Yes.
What is the age of the patient?
Age of the patient is 12-year-old, sir.
What answer I wanted is, younger the patient, 6 months duration, is not 1 month duration, 6 months duration.
Yes.
Answer I expected was probably neck is the most common set for congenital swelling. That word.
Congenital. Yes, sir.
So because the age is just 12 years.
12 years. Yes, sir.
Now go to the next slide.
Yes, sir.
So there are a few things like this. What is this relevance of so many things you have written, starting from syncope to deafness to weight loss, loss of appetite, bony pain, jaundice? What is that you want to ask in a 12 years girl?
Sir, usually lymphoma is common in young age also. Bimodal, this will be there. So I am just ruling out the malignancy, sir.
1 minute. Even if I agree, I got your point, but remember, don't stretch your imagination so much and get into trouble in the examination.
Yes.
If you tell me, young girl, 6 months duration, swelling and fever, I may suspect leukemia, and definitely I respect that. But more than that, all this bone pain, jaundice, see, you have gone into so much about ulceration in the oral cavity,
Yes.
dyspnea, strides, hoarseness.
Yeah, why do you want to ask for a difficult dysphagia, dyspnea, or a stridor in a lateral neck swelling?
So don't. Don't try
As
to
a
always.
postgraduate student, you should, whenever there's a midline swelling, these things are relevant. But for a lateral swelling, probably yes, it's quite of a stretch of imagination.
Yes. Sir, I wanted to rule out Zenker's diverticulum and other.
Yeah.
Madam, always remember common things are common.
Things are common.
Yes.
Common things are common. Uncommon things are uncommon. And rare things are
Rare.
rare. Okay. So
Yes.
in other words, don't have to go to that extent. What we expect you to remember is how is the progress of the swelling?
Yes.
How it is growing slow, steadily, any
Slowly.
rapid pace. Anytime it has become lesser in size, big and inflammatory, or
Yes.
is there a swelling, or any time, any, what is that? Secondary changes. Like you said, no, short duration tuberculosis, you suspect a sinus.
Yes.
Other than that, you can't go to this level of asking so many questions. Okay. Jaundice.
Yes.
Syncope. What is that you had in mind, syncope? Why did you ask?
Syncope, because in lateral neck swellings, there could be chances of carotid body tumor, sir.
Oh, you don't go to that level. That's what I tell. If it is there, you tell. But in this
Yes,
specifically in this patient, nothing was required. Okay, you will get
yes.
into trouble. Okay.
Yes. Yes. Should I move to the next, sir?
Yeah, please go ahead.
Yes. So this is the image of the patient, sir. General physical examination. Patient was examined in a well-lit room after taking consent of the patient. Patient was cooperative, conscious, well-oriented to time, place, and person. Moderately built, moderately nourished. Pallor, cyanosis, icterus, clubbing, and generalized lymph node adenopathy all were absent. Pulse is 72 beats per minute. Respiration is 18 cycles per minute. Temperature febrile. Weight is 31 kgs. Height is 144 centimeters. So we calculated BMI and it is 21.5 kg per meter square. Examination of neck. A solitary swelling of 7 into 5 centimeters was seen on the left lateral upper third of the neck, extending from 2 centimeters from the angle below the angle of mandible and 3 centimeters above the clavicle, and 2 centimeters lateral from midline. And oval shaped swelling was seen. Smooth surface, well-defined margins. There was no visible pulsations. The swelling did not move on deglutition. Skin over the swelling was normal with no sinus, ulcers, scar, or dilated veins. There was no redness. Trachea appeared to be in the midline. No other swellings in the neck were noted. Palpation. All the inspectory findings were confirmed, and palpation of the swelling was done by slightly extending the neck and standing posterior to the patient, behind the patient. No local rise of temperature was seen. No tenderness. Solitary swelling of size 7 into 5 centimeters. Located over the anterior triangle of the neck on the upper third of anterior border of sternocleidomastoid muscle. Ovoid in shape, smooth surface, well-defined, smooth margins were present. Soft in consistency, slight restricted mobility was present. Slip sign was negative. Compressibility was absent. Fluctuation positive. Transillumination test was negative. And the swelling was not fixed to the skin. No pulsatile, cuff impulse absent. The swelling was reduced on the contraction of sternocleidomastoid muscle. Left carotid pulsations felt medial to the swelling. Cervical lymph nodes not palpable. No thyroid nodules were palpated. Percussion, dull note over the swelling present. Auscultation, no bruit or murmurs felt. Examination of oral cavity. Lips, tongue, floor of mouth, soft palate, uvula, hard palate appears to be normal. No indurations felt in the oral cavity. Upon protrusion of tongue, no deviation of tongue noticed. Teeth, dental caries were present. Swelling not felt on bidigital palpation. No parotid enlargement was seen. Ear, nose, scalp examination. In ear, we examined the external auditory canal, which was normal. There was no discharge. Then nasal cavity, normal, no discharge, no discharge or no any growth or foul smell. No swellings present in the scalp. Systemic examination, cardiovascular system, S1, S2 heard. No added sounds. Respiratory system, bilateral normal vesicular breath sounds were present. Abdominal examination, soft, non-tender, no organomegaly. Case summary. A 12-year-old female presented with the painless, progressive, solitary left lateral neck swelling in the anterior triangle below mandible. Since 6 months of size 7 into 5 centimeters was seen on left upper third of sternocleidomastoid muscle. Ovoid in shape, smooth surface, regular margin, fluctuation positive. The slight side-to-side mobility was present. Transillumination test was negative.
Dr. Meher,
Yes, sir.
Dr. Meher, can you hear me?
Yes, sir.
As per your description, the swelling is present in the anterior triangle of the neck.
Yes, sir.
The first thing, what are the boundaries of the anterior triangle? Second thing, in your description, you mentioned thyroid nodule was not palpable. Thyroid nodule.
Thyroid, yes,
So
sir.
one
Thyroid
question
gland.
is, thyroid lobes were palpable. You palpated thyroid gland, yes or no?
Yes.
Yes, you
Yes, sir.
palpated thyroid gland.
We palpated the anterior aspect of neck, sir, but there was nothing palpated. Sir.
Nothing was palpable. So what is the relevance of putting this thyroid nodule was not palpable?
Sir, in
What are the
sometimes in
boundaries of the anterior triangle first? Anterior triangle and the posterior
anterior
triangle.
triangle is bounded medially by the midline, sir, laterally by sternocleidomastoid muscle, and inferiorly by clavicle.
Okay.
Yes, sir.
And what are the boundaries of the posterior triangle?
Posterior triangle, posterior part of sternocleidomastoid muscle, trapezius, and clavicle. Sir.
Posterior part, what is the meaning of that?
Posterior
Sternocleidomastoid have different parts.
no, sir,
One
posterior
third, middle
border.
one third, lower one third, that we know, but borders are more.
Yes, sir, borders, posterior border of sternocleidomastoid.
And the posteriorly?
And anterior border of trapezius muscle, sir.
Anterior border.
And
Yes. Okay. Your swelling was, fluctuation test was positive. So what do you
yes,
think? What it could be?
sir, usually fluctuation test is positive when there is a cystic swelling, sir. When there is a fluid filled swelling. So when if in the last, any cystic swelling can show fluctuation positive.
Yes, that is very correct. But your patient is 12-year-old, 6 months duration, cystic swelling with fluctuation positive, lateral side, no neck, no lymph nodes in the neck.
Yes. It could be a congenital branchial cyst, sir, because of the position of the
Congenital branch.
position of the swelling, sir.
What are the points in favor of the branchial cyst?
Branchial cyst first point is it is although it is a congenital swelling, it is not present since birth. It comes later on in the life, sir. Mostly in the third decade, but as our patient was slightly younger than what was expected to be, there will be swelling in the anterior triangle usually one major point is when you make the sternocleidomastoid muscle taut, it reduces in the size, stating that it is in the deeper part of sternocleidomastoid muscle.
One more thing you can add. What is the exact location that you have mentioned? Location is very important as far as branchial cyst is concerned.
Location is important, sir. Usually branchial cyst is present in the upper.
I am talking about your case only. I am
yes,
not talking about the usually and unusually. What is the location of swelling in your patient?
It is upper third of the sternocleidomastoid, anterior border of sternocleidomastoid.
So does it match with the branchial cyst or not?
It does.
Yes or no?
Yes, sir.
Yes. Yes, please. Yes, faculty.
Do you want to give any differential diagnosis?
Yes, sir. Differential diagnosis, it could be as we did slip sign, which was negative, but still we can expect it to be a lipoma. We can expect it to be a cold.
Yes, yes.
We can think that it could be a cold abscess as well. It could be a TB
So
lymph.
what is against lipoma? What is against lipoma?
Against lipoma, fluctuation test will be positive in lipoma as well, as it shows pseudo fluctuation. But one test which rules out lipoma is slip sign. Slip sign is negative.
And what about transillumination?
Transillumination test will be negative in lipoma, sir. And but one more thing is when the sternocleidomastoid muscle is taut, in the branchial cyst it reduces, but in lipoma it is a subcutaneous swelling. It becomes more prominent.
So you cannot have deep lipomas deep to the fascia.
We can have, sir.
Yes. So what other transillumination negative can you think of?
It could be a
Another cold abscess.
As this young and TB is more common in India, so we could suspect it as a cold abscess as well.
But then corroborative evidence, other evidence is not there. Yes. Anything else?
And then we can also suspect lymph cyst. It is an acquired cyst. Same thing, soft swelling, transillumination negative, and fluctuation positive will be there, sir. Transillumination positive, so sometimes it will be.
And this be
yes. What can it be a dermoid cyst? Did you think of a dermoid cyst at this location?
Yes, dermoid cyst sometimes subhyoid dermoid cyst can be seen. Sequestration dermoid cyst can be seen in that location, sir. But in dermoid cyst there will be.
They are usually located in the midline. They are usually located in the midline of the neck. It's rare to see the lateral aspect. Yes. Any other? Why don't you think it's if you are thinking of congenital? Why is it not a cystic hygroma?
Cystic hygroma is usually seen in infancy, sir, in newborns, and it is a brilliantly transluminant swelling. So we have to rule it out, and it has nodular surface as well. And
can this swelling be some tumor from the thyroid that may present as a swelling in the lateral side of the neck?
Yes, sir. Usually, papillary carcinoma of thyroid can present as a swelling in the lateral side of the neck, sir. So that's why we examined the thyroid gland to see any nodules are present in the thyroid gland to rule out that extensions in the lateral part of the neck.
Okay. Does age of the patient match with your this finding?
No,
what
sir.
is the common age for the papillary carcinoma thyroid?
It is not the younger age, sir. It is 30, 35.
Is it papillary?
No, sir. No, sir. We'll rule it out.
Sure.
Okay. Yes, then any other differential diagnosis coming to your mind?
Sir, it could be because of age, patient of the age. We can also suspect pyogenic lymphadenitis.
Pyogenic lymphadenitis, okay. But then those signs, acute signs are not there. Yes, most of the things. Okay. Any enlargement from the salivary gland, is it possible?
Yes, sir. There will be silidinitis in patients.
Okay. Any tumorous enlargement from probably a submandibular gland?
Dr. Meher, one important thing you should remember. In the exam, you cannot go on telling 20 differential diagnoses in a given case. Okay. Examiners will definitely ask you to get a broader idea. You have to narrow down to few important things here. Number one, you said 6 months duration and a 12 years old girl. So obviously that itself will rule out tuberculous lymphadenitis. What is the reason? That question I will ask. First question.
Yes.
Why I say it is not possible to get a cold abscess? Reason? Simple. You said common in India and all the thing you said, but I am telling you it is not possible in this patient. Reason?
Shorter duration, sir.
Shorter means? So every disease you should know the behavior of the disease. 6 months, what happens to the TB lymphadenitis usually?
Yes, sir. Usually TB lymphadenitis will be painful, sir. Painful.
Not painful. No. What happens to the nature of the nodes?
It will be matted. Enlarged lymph nodes will be there, sir. Matting will be there.
By 4 to 6 weeks, you will get cold abscess, sinus formation, and all the other constitutional symptoms. This is how you try to say in the exam. It is not possible to think of lymphadenitis like tuberculosis.
Yes.
You said pyogenic lymphadenitis means what? What is that you had in mind? Pyogenic, the word itself should tell you, some pus focus and all that thing.
Yes.
And your swelling is basically cystic or firm or a hard swelling?
It was cystic swelling, sir.
So fluctuant swelling, yes or no? Yes or no?
Yes, sir. Yes, sir. Fluctuant swelling.
So when in the exam, when you are asked, you have to narrow down to the swellings which are fluctuant and
Yes, sir.
cystic. So in other words, you have got cold abscess. Yes, few things. Cystic hygroma has been asked to you. Suppose I ask you, why not it's hemangioma? What answer you will give?
In hemangioma, sir, it will be a pulsatile swelling, sir.
Not necessarily. Low flow and high flow are there. You may be knowing about it. So
yes, sir.
the pulsations are classical of a AV malformation. Nowadays we don't use that, but still low flow status, vascular malformations can have
and it will be
low flow. It will be cystic, it will be fluctuant, it will be transpiration negative. But what other sign may be present?
Skin will be bluish discoloration. Skin will be bluish.
Bluish, it happens where it is from the skin and subcu. Capillary, cavernous, you have AV malfunction. So cavernous variety, space. So there may be one physical sign, may be present. What is that in malformations?
Bruy will be endoscopy.
Again, I said, no, they are high vascular, high flow, you will get bruy. What I wanted answer was compressibility.
Compressibility, yes.
So when you have a soft fluctuant swelling, when the transformation is negative, obviously you have ruled out cystic hygroma. Now you move on to hemangioma. So this one physical sign is expected for you to tell in this examination because you are not thinking of anything which is hard. So there are several questions which are asked to you. Like you said initially, carotid body tumor. So that's why you asked for syncope. You don't suspect that in this 12-year girl. Okay. So the other few examination you should mention in here is the other side, neck. Did you get any branchial cyst? Fistula, branchial cyst, they can be sometimes bilateral, including carotid body tumor, etc.
Yes.
Bilateral. Okay.
Yes, sir.
You understood the question?
Yes, sir. Understood, sir.
So next important thing is why it becomes less prominent on sternomastoid contraction test. Tell me. You are there? Yes.
Sir, to rule out hemangioma, that's why I had mentioned compressibility test.
It is a very, very important finding. No, 1 minute. It is a very, very important finding. Sternomastoid contraction test, because both sternomastoid and branchial cyst arises from second branchial arch.
Yes,
both, including the muscle. So, in fact, partly it is adherent to the muscle, deep to the muscle. That limits its mobility. Okay, it is stuck to the muscle actually on table. So, so these are the few things which are. So you narrow down to cystic swellings only because it is fluctuant.
Yes.
And transformation negative. Cold abscess you ruled out because 6 months duration you don't get sinus and everything will be there. You landed with the branchial cyst. Yes. Why it is not transluminant?
Branchial cyst the cyst is lined by epithelium, sir, a squamous epithelium.
No, question asked was why it is not transluminant.
Its contents are cholesterol crystals, sir. So
also inspissated material. Inspissated material. That is why it is not like a cystic problem. Okay. So transformation is negative. So you are suspecting a branchial cyst. Then lipoma you have ruled out in the sense 12-year girl. How to expect a 12-year girl to get? So you should know the every disease, the behavior of the disease, how it progresses, So that can help you in giving a narrowing down. One or two things you get narrow and come to reasonable diagnosis. If the
Yes.
question is asked like other things, you say unlikely, unlikely, unlikely. This is how you go on telling. Come to one or two diagnosis. Sir, somebody else can take. Dr. Ajay Khanna sir is joined. Sir, please, sir.
Yeah, what is the difference between a hemangioma and a venous malformation?
Sir, in venous malformation, there will be irregular swelling, sir. It will be irregular. In hemangioma, it will be a regular swelling. And AV malformation is congenital. Hemangioma is
Which is a tumor and which is ectasia?
hemangioma is a tumor. AV malformation is an ectasia.
Which is present at the time of the birth?
Hemangioma.
No.
AV malformation.
Venous ectasia will be present at the time of the birth.
Yes.
Which can regress? Hemangioma or venous ectasia?
Hemangioma.
Hemangiomas can regress. Yes. If you do the histology of that, is there any difference between these two? Yes, there is a difference. If you ask your histologist, there is a difference between a venous ectasia or venous malformation and the hemangiomas. Which can be treated by the medical treatment? Venous malformation or the hemangioma?
Hemangioma can be treated medically, sir. AV malformation requires surgical treatment.
Which medical treatment you will give for the hemangioma? This is the beta blockers, Provisional. Provisional is the drug of choice for regression of the hemangioma. But they will not probably respond to the vascular malformation.
Yes.
Did you keep a possibility of lymphangioma in your patient? Have you
Yes,
kept
sir.
a possible lymphangioma?
Yes, sir, but the swelling was not.
So what is
the
against
same.
the lymphangioma in your patient?
The swelling is not transilluminant, sir.
Okay. But do you know lymphangiomas, what are the things which are there? It's like a single cavity is there or there are multiple small cavities are there?
Multiple small cavities are there, sir, in lymphangioma.
So it may not be transparent.
Yes, sir.
Okay. It may be transparent, but it may not be also transparent. So I think these are the two most important things which you have to keep. And the third is the cold abscess, no doubt about that.
And compressibility will be positive in lymphangioma.
Yes, maybe or may not be. Compressibility is a feature of the venous malformation.
Yes.
Lymphatic malformation may not be compressible. Yeah.
Yes.
Okay. So if you think it is a cold abscess, from where the cold abscess can come in this area?
Sir, through the tonsils or blood spreads. Lung.
And
Lung.
any other place from where the cold abscess come in this area?
Usually, first is tonsils, sir. Second is through the blood, and third is lungs.
Anything in the occipital? Anything in the occipital region from where it can come? Caries spine?
Yes, sir.
Caries spine?
Yes, sir. Yes, sir. Caries spines from the cervical spine, sir. Because from the cervical spine, it can come to this area, sir.
That is
Usually,
one of
sir, this will patient will, if there is cervical spine involvement, there will be neck rigidity, neck pain, and.
Did you examine the cervical spine in your patient?
Yes, sir. I have ruled out the neck movements, restricted neck movements and neck rigidity.
Okay. Dr. Shanal, you can carry on. Yeah.
Yes, Meher.
Yes, sir.
So can we proceed with the imaging and whatever the diagnosis is over now? So
yes,
next, what will you do?
So we did a USG scan. USG scan.
Why? Why?
To know where it is exactly located. To know the depth of the.
You said no already. You are a good clinician, surgeon. You said it is a lateral neck swelling, sternum-mastoid relationship. You are told very clearly, deep to it. So still, why do you want?
To confirm it, sir, to confirm the location, to confirm
Maybe.
whether it is compressing something, to know the depth of the swelling, sir, whether it is compressing anything, any vessels or anything. To
Just for a little bit of more interest to get it, what are the different 4 types of bronchial cyst? And you know the classification goes in the famous one name.
Yes, sir. I don't know the name of the classification, but it is divided into 4 types, sir. First type is it is anterior to the sternocleidomastoid muscle. Type
yeah, please go ahead. Yes.
Type 2 is in the one which we did, sir. It is on the upper third of the sternocleidomastoid muscle.
So it is in relation to one is platysma and sternomastoid. Second one is between the sternum.
Yes, sir. First one is deep to the till the platysma. Second one is deeper to the deep fascia, sir. Third is at the bifurcation of carotid arteries. Fourth is
pharyngeal wall. Why should you know this different positions?
To see whether while operating there should be no damage to the underlying vessels. That's why we have to.
So the idea of doing the ultrasound is you can is excellent for a solid and cystic, especially in the neck. So in relationship, the first of site of origin and vessels, especially with if you add the Doppler, you can still do a better job. Actually, just to complete, this is the classification goes in the name of Bailey classification. Okay, Bailey. Okay. Nishikant sir, please take
go ahead, Rudu.
Mayor, please share your PPTs and CT images.
Sir, CT images are completely contradictory to my examinations.
No, it doesn't matter irrespective of whatever your examination. Let us see the what if you are done now.
Yes, sir. These are the CT films, sir.
Please share the PPT.
Please share, order.
Yeah, we can't see the screen.
We can't see the screen.
You may have to again share like what Dr. Kanakwe said some time back. Slides
Okay,
have.
sir. Yes.
We are able to see that.
Are you able to see?
No. First of all, we are online, but in the online, when you put no, select the best few and try to project them as much you can do. Because otherwise, very difficult for us to make out what is there. Just you have to tell the report, I think, only see what we can make out. So difficult in this.
Yes, sir.
Whenever you project such things, no, you don't drag it and make it big. You have to increase them proportionately. And I can imagine that this is a one film available which you have taken the picture. Correct, no?
Yes, sir.
I think probably you can go with the report. You can see that lesion.
This is the neck ultrasound report, sir. This shows a well-defined hypoechoic lesion with internal echoes measuring 39 into 36 millimeter is noted in the left submandibular level with echogenic content noted within and the surrounding reactive lymph nodes and the lesion causing mass effect over internal jugular vein. This is a epidermal or sebaceous cyst. This is a CT scan report, sir. Large, well-defined, thin-walled, smooth, round to oval, hypodense lesion with thick internal septa of size 4.5 into 4 0.4 into 6 centimeters, noted arising from the left carotid space at the level C2, C5 vertebrae, causing mass effect in the form of compression of left internal jugular vein and left common carotid artery medially and left sternocleidomastoid laterally, likely epidermoid cysts. Few subcentimetric lymph nodes noted. This is FNAC report, which also says that it is a sebaceous cyst.
So what is this epidermoid cyst deeper to the sternomastoid in that space? What do you understand by this epidermoid cyst? Sebaceous cyst arises from what structure basically?
From this cutaneous layer.
So then how you explain this 12-year girl having this problem? So I know that you have done FNAC, all that is true, but I don't know. So these anomalies are known in the neck. That is the branchial cleft cyst anomalies, basically.
Branchial cleft. Yes.
Oh, it is the branchial cleft cyst anomalies. It's not just, if you just tell epidermoid cyst, sebaceous cyst, no, I don't think we should accept at this stage, whatever FNAC has told you. I'm not trying to say sebaceous cyst, what we understand it. So branchial cleft cyst anomalies can have all this kind of thing. Yes. What I understand. Sir, please, sir.
What are branchial arches, Mayor, madam? Mayor?
There are 6 branchial arches, sir, out of which fifth disappears just after formation in the intrauterine life, fourth week of intrauterine life. So first pharyngeal arch will be mandibular arch, second will be hyoid arch, third will be it is a third pharyngeal arch. Name is not given. Fourth and then sixth pharyngeal arch.
Which structures will arise from these arches?
First, mandibular arch, sir. Their muscles arising from it is incus malleus, mandible, maxilla, and maxillary artery, and trigeminal mandibular branch of trigeminal nerves.
Second arch?
Second arch is also called as hyoid arch, stylohyoid, hyoid, facial nerve, no, stapedial artery and facial nerve will be the content. And third arch is glossopharyngeal nerve, sir. Glossopharyngeal nerve and the
What is the relation of the brachial cyst to the sternocleidomastoid? Classical relation. Brachial cyst and fistula?
Sir, in brachial cyst will usually be seen in the upper part of the sternocleidomastoid, sir, upper third, sir. Whereas fistula, that is congenital branchial fistula, will be present in the lower part, but acquired after bursting of the branchial cyst, it can be present in the upper part also. Acquired branchial fistula.
What is course of brachial fistula?
External orifice will be in the anterior part of the sternocleidomastoid muscle, sir, and the internal orifice will be posterior to the tonsils.
Passes between
These major vessels like eyes, internal carotid artery, external carotid.
Okay. What are different levels of lymph nodes?
So there are total 7 levels of lymph nodes in the neck, sir. First is divided into 1A, 1D, that is submental 1A, submandibular 1B, and then we have second is upper jugular nodes, and third is middle jugular nodes, and fourth is lower jugular nodes, fifth is posterior triangle lymph nodes, sixth is pretracheal prelaryngeal, and Seventh is mediastinal lymph nodes.
What are stages of tuberculous lymphadenitis?
So there are 5 stages of tubercular lymphadenitis, sir. Stage 1, there will be enlarged lymph nodes. There will be inflammation of lymph nodes. That's why lymph nodes will be enlarged. In stage 2, there will be periadenitis. The peripherals of the lymph nodes will be inflamed. In stage 3, matting happens, and then there will be caseous necrosis will be found. In fourth stage, there will be a cold abscess which can lead to collar stud sinuses. In fifth is sinus formation.
Dr. Meher, can you hear me?
Yes.
You mentioned total 7 levels of the lymph nodes in the neck.
No, not 6 in the neck, sir. 7th in the mediastinum.
6 in the neck. Very correct.
No, in fact, there are 10 group of the lymph nodes in the neck, you know. We always talk about 6 or 7, but there are 10 group of the lymph nodes which are there. Like pre-auricular is different, post-auricular is different, occipital is different. Okay, we do not talk about these in the 6 and 7 groups. So, in fact, there are total 10 group of the lymph nodes in the neck. Mayor, what is collar stud? What do you understand by collar stud?
Collar stud is when there is a cold abscess formation, sir. The pus will be trying to come out, and it will come out through the small sinuses in the swelling. So it will give like a appearance of. It will appear like
what is? So what does it penetrate? What does it penetrate?
Skin, sir.
The pus which is there, which structure it penetrates to make it collar stud? It penetrates the deep fascia.
Deep fascia.
Okay. So you will find there is a small abscess superficial to the deep fascia, but there is big abscess below the deep fascia. And that is in fact the collar stud. You know, collar stud is a type of the button. Do you know about that? Collar stud button?
Yes, sir.
Have you ever been to Lucknow? Have you seen Lucknow kurtas?
Yes, sir.
You know, there is always a button which is there. That is called a collar stud. So it has got a big ring down, then there's a connector is there, and then there's a small ring up.
Yes, sir.
Okay, so that is a collar stud. So by that name comes. You know, any other disease can cause the collar stud abscess apart from the tuberculosis? Any other mycobacterium?
Actinomycosis.
Actinomycosis can go. Any other mycobacterium which is there? Lepri. Okay, which causes a leprosy.
Yes.
Okay, so that can cause the collar stud abscess. Any other place where you can get the collar stud abscess apart from the neck?
In the axilla, sir. In the groin.
No, classical. It is not usually in the axilla. Somewhere classically it is there. The palm.
In the palm. Yes.
Okay. So, the palmar aponeurosis.
Yes.
So that abscess can burst through that palmar aponeurosis, can lead to a collar stud abscess. So what do you plan in this patient, keeping the CT in your mind and the clinical findings, which we probably all of us do not agree that it is the epidermis cyst. You know? We all of you, we do not agree with that. So what is the plan?
Sir, we will plan for the excision of the cyst, sir.
Okay. Under which anesthesia you do?
Under general, sir.
You have to do in the general anesthesia. No? If you do epidermis cyst, you could have removed in the local anesthesia.
Local anesthesia, but here we do underlying vessels, so better to do it.
How will you give the incision?
Sir, there is one incision which is commonly used, that is step ladder or stair ladder incision, where two parallel incisions are made on the neck to preserve the structure, and to see the course of the brachial cleft.
You are confused with
In the
the
case of
branchial
branchial cyst or
fistula.
branchial sinus or fistula?
She's
No, multiple incisions are given in case of the, if
Fistula.
you're suspecting it's a branchial sinus or fistula.
Fistula, sir. Multiple
It's the branchial
incisions.
cyst. No? So branchial cyst can be tackled by one incision only. Okay, we'll give you a transverse crease incision in that.
Yes.
Okay. Then how will you approach the, if it is a branchial cyst?
Sir, we have to completely remove the cyst. Otherwise, there will be.
So what are the important vital structure which will come in picture?
Sir, there will be hypoglossal nerve will be there, sir.
So where do you find the hypoglossal nerve?
Just
Where do you find the hypoglossal nerve?
in the anterior triangle, sir, in the crossing the sternocleidomastoid muscles.
It runs near the bifurcation of the carotids.
Yes.
No? So you have to be very careful about the carotids here.
Yes.
Which nerve passes through the carotid sheath?
Marginal branch of mandibular nerve.
Carotid sheath.
Ansa cervicalis and sympathetic chain of vagus
Which
nerve.
nerve? Vagus nerve. So that is most important structure.
Yes.
Now, if it is a case of lymphangioma, then what you will do?
We do the excision.
Hmm?
Excision.
So what precautions you have to take when you do the excision of a lymphangioma?
We should see whether it is connected to the thoracic duct or there is connection or not. Otherwise, we might injure the other lymphatic system.
No, there are macrocysts and a microcysts are there. What is sometimes called as a rice seed appearance.
Yes.
So there are very small microcysts which are there. Until unless you clear those, there is a very high chance of having the recurrence. So that is why now there are other techniques for the
Yes, sir.
treatment of these. So what are the other techniques apart from the surgery for these cases?
Sir, injection sclerotherapy can be given. Sir.
Injection sclerotherapy can be done.
Okay,
Sclerotherapy you are going to give?
Okay,
Which sclerotherapy?
Okay, 432, sir, which is derived from
That is one. Yes.
Then you can go for sodium diethyl.
Sodium tetradecyl sulfate.
Tetradecyl sulfate.
Sodium tetradecyl sulfate can be used. Hypertonic glucose can be used.
Yes, sir.
Boiling water can be used.
Yes.
All these are the sclerosants which can be used. It has been even used for the branchial cyst also.
Yes, sir. Branchial cyst we use okay for
and use that, yes. Okay.
So, Meher, suppose it is a tuberculosis, how will you manage?
Sir, we start the patient on antitubercular drugs.
How many months?
6 months.
How many months?
6 months. 6 to 12.
6 months.
And what are those 4 drugs which you give?
Pyrazinamide, rifampicin.
Yes.
Isoniazid.
Okay. What are the doses of that?
Sir, rifampicin is 600 ml. For a baby, for a younger age group, it can
Tell
be
per
given
kg body weight. Per kg body weight, how do you remember that?
1 to 2 gram per kg.
How much is the rifampicin?
Usually in adults it is given as 600.
You have to always
Dosing
tell the dose in per kg body weight. So just for remembering, rifampicin is 5 milligram per kg body weight.
Yes.
No, sorry, isoniazid is 5 milligram per body weight. Rifampicin is 10 milligram per kg body weight. Ethambutol is 15 milligram per kg weight. And the fourth drug is
Pyrazinamide.
pyrazinamide, and that is 25 milligram per kg body weight. By that, you can remember how much is the dose for that. Okay.
It's 5, 10, 15, and 25. Easiest ways to remember the dosing. Never tell like this that 600 milligram or 450 milligram or 300 milligram. Always and always dose anywhere should always be as according to body weight. Milligram per kg body weight.
What are the side effects of these drugs? Rifampicin?
Rifampicin, orange colored urine.
You have to always tell your patient, because the patient will come next day to you and he will say that I am passing now the red color urine.
Red color tears and urine.
What are the other side effects of that? Other side effects of rifampicin?
Nausea, vomiting.
Nausea, vomiting, and where you may have to stop the rifampicin.
There will be thrombocytopenia.
What thrombocytopenia? Something in the liver.
Abdominal pain.
Hepatotoxicity. Okay, so whenever a patient of the ATT comes to you with nausea, vomiting, always get his LFT, get his enzymes.
Yes.
Okay, and you may have to either stop the drug or decrease the dose of that. Okay, you have to change that. What is the toxicity of the INH?
Renal toxicity.
What else? Neurotoxicity.
Neurotoxicity.
Neurotoxicity. Okay. Neurotoxicity. Ethambutol.
Ocular eye side effects, sir. There will be diplopia. There will be blurring of vision.
Ocular neuritis. Yes. When do you have to do the excision of the lymph nodes? What is the indication of doing a surgery in case of the tubercle lymphadenitis?
Sir, if the patient does not react to the medical line of treatment, and if there is matting of lymph nodes, and you suspect that it is a malignancy, so you go for a resection of the lymph nodes, radical neck modified radical neck dissections. We can go for, sir.
Okay, if we are in doubt about that, number one,
yes,
surgery is done always in case of doubt about that.
Yes,
second, if you want to have the, like whether it is a rifampicin resistant or not,
yes.
you have to do the biopsy for that. Yes. Third is you are giving the patient treatment, the patient is not improving. Fourth is the patient has improved, but still there is a residual disease is there.
Yes.
So all those are the indications for carrying out the surgery for the lymph nodes in the case of the tuberculosis. Dr. Kanavel, can we stop now? Dr. Kanavel?
We should allow the candidate to have clarity doubts from panel. Do you have any doubts?
Ask any question from us?
No, sir. All my doubts are clear, sir. Thank you, sir.
Okay. Okay then.
Thank
Thank you
you.
very much.
Thank you, sir. With the permission of the faculty, we call the session a close. And I thank the invited faculty, Professor Pradeep Sharma, sir, Dr. Anthony Rosario, Dr. Manjunath Puttanavar have to leave earlier. So thank you for them. And thank you, Anna, sir. Thank you, Rajgopal, sir. Thank you, Nishikant, sir, for staying with us because of my connectivity challenges. And I thank both the students, Dr. Meher and Dr. Neetu, for presenting the case this evening. And I also thank the respective faculty who contributed with students, Dr. Shyam from GMC Shinag Jammu, and Dr. Nishikant, sir, from Vijaypura Alamin. Thank you for permitting your students to present these cases. So we will meet coming Friday. Good night, everyone. Faculty, can we call the session a close, sir?
Yeah,
Yes,
please.
Yes, sir.
Yeah.
Good night, sir.
Good night.
Good night,
Good
sir.
night.
Good
Good
night,
night,
sir.
everyone.
Thank you.
Good night.
Thank you, sir.
Thank you. Nice presentation.